a therapeutic procedure like a thoracentesis. Much less often, it occurs spontaneously. The client we are going to discuss had a penetrating chest wound. We will want to assess for a tension pneumothorax, which occurs when air builds up in the pleural cavity, causing collapse of the nearby lung. It can also push the heart toward the unaffected side of the chest. When it comes to risk for and prevention of pneumothorax, there isn't really a lot that people can do. Certainly, quitting smoking can reduce the risk of lung diseases, which might contribute to a spontaneous pneumothorax. And it is also important to wear seatbelts and avoid activities that might cause injury. In this case, the client was involved in a knife fight. We'll begin by reviewing the record from the paramedics who brought the client into the emergency department. The client was experiencing sudden shortness of breath, pain with breathing, sharp pain on one side of the chest, tightness in the chest, tachycardia, progressive cyanosis, a drop in blood pressure, probably leading to shock, and engorgement of the neck veins, indicating tension pneumothorax. He has many of the signs. In fact, if you added a dry, hacking cough, he would have all of them. To manage this client, an occlusive dressing was placed over his chest wound, and the dressing was taped on 3 sides. This prevents further lung damage but allows air to escape during exhalation. Next, a chest X-ray was done to confirm the pneumothorax, followed by examination of the wound to determine the need for surgical intervention. The key intervention, however, was inserting a chest tube to remove air from the pleural cavity and reestablish negative pressure. When taking care of a client with a chest tube, remember to assess for subcutaneous emphysema, difficulty breathing, and signs of hemorrhage. Watch for signs of infection. Make sure the tubing is intact. Watch for proper functioning of the chest tube drainage system, and change the client's position every 2 hours. Since we are looking at cases here in a hospital, let's discuss a client who is in the ICU with acute respiratory distress syndrome, or ARDS. You probably remember that ARDS is a pulmonary disorder characterized by damage to alveolar capillaries, increased vascular permeability, pulmonary edema, impaired gas exchange, and decreased surfactant production, with atelectasis and severe hypoxia. About 40% of people who develop ARDS die, despite treatment. What are the risk factors for ARDS? Multiple trauma, burns, infections, particularly gram-negative sepsis, shock, inhalation of chemical toxins, aspiration of gastric contents, near drowning, drug overdose, disseminated intravascular coagulation, or DIC, and emboli, to name just a few. What signs and symptoms would you look for? Restlessness and anxiety, dyspnea, cyanosis, tachycardia, hypotension, hypoxia, and crackles. The diagnosis is made through ABG analysis, chest X-ray, pulmonary artery wedge pressures, and predisposing conditions. This client is on mechanical ventilation with oxygen and PEEP helping to keep the lungs partially expanded and to prevent the alveoli from collapsing. PEEP should always be used cautiously with clients who have COPD because the blebs that commonly develop with emphysema and other chronic lung disorders can rupture easily. Back to our client. The nurses have been turning her regularly from the supine to the prone position and back again. This seems to improve her PaO2. Hemodynamic monitoring is continuous. Since PEEP increases pressure within the thorax, it will decrease cardiac output. If a pulmonary artery catheter is in place, you would monitor for changes in cardiac output. If the client doesn't have a pulmonary artery catheter, you would monitor for changes in blood pressure and signs of decreased perfusion. Earlier, she was given dobutamine for cardiovascular support and, of course, IV fluids. It is a delicate balance to manage the hemodynamics so that the client's PaO2 is within normal limits for her age, and her SaO2 stays above 90%. And of course, we need to identify and treat the underlying cause, which in this case is gram-negative sepsis. Let's talk about mechanical ventilation for a moment. What are 3 reasons a high-pressure alarm might be triggered? Secretions in the airway or tube, the client biting the ET tube, or an anxious client whose respirations are not in sync with the ventilator, also called bucking the ventilator. What are the nursing interventions for a high-pressure alarm? For secretions, it's to suction the client's airway or tube. For biting, we put in an oral airway, and for bucking the vent, the client might have to be sedated. What might set off a low-pressure alarm? A leak in the system, such as a deflated cuff or a disconnection. We fix the cuff by checking the cuff pressure and re-inflating it, and we remedy a disconnection by identifying the disconnection site and reconnecting accordingly. Remember that when clients have an endotracheal tube in place, their ability to communicate verbally is impaired. This can increase their anxiety and thus their oxygen demands. So we explain to clients how they can communicate with us. 3 common methods employed are hand signals, with nodding, a magic slate, and an alphabet board. Select the method that will be the easiest for the particular client to manage, and be sure the family also understands how to use the selected communication method. Nursing in the ICU includes caring for clients in a calm manner and educating the family about interacting with the client in a calm manner. Always talk soothingly and frequently to clients on ventilators to help reduce their anxiety. Explain everything before you do it, and be scrupulous about aseptic technique. Are you aware of the respiratory complications of ARDS? One of the things the nurses in the ICU will watch this client for, ARF. To understand ARF, you must remember that the function of the lungs and the respiratory system is to exchange gases, specifically oxygen and carbon dioxide, between the atmosphere and the blood. Respiratory failure develops when the exchange of one or both of these gases is impaired. That is, when too little oxygen is transferred to the blood or too little carbon dioxide is removed.
Let's look at some definitions in a chart that might make things a little simpler. Hypoxemia, inadequate oxygen transfer to the blood. Decreased oxygen decreases arterial